Good morning, everyone. This is Faith. All right, we're going to try that again. Good morning, everyone. It's Faith Rents, Director of Statewide Benefits in the Department of Human Resources. It is 10:01, and we're going to go ahead and convene this morning's combined meeting of the Health Policy and Planning and Financial Subcommittees of the State Employee Benefits Committee. Carol Mick here to my right, and she has confirmed that we do have quorum of both subcommittees. We've got a rather packed agenda this morning, so I appreciate everyone joining, and we're going to go ahead and I think dive in so we can try to be as efficient as we can with our time this morning. We will be bringing most of the items on today's agenda before the full committee when they meet next Monday on the 25th. So having said that, just a reminder, this is a public meeting. The meeting is being recorded. The recording will be posted on the SEBC webpage later this week. So our first item of business this morning is approval of our recent subcommittee minutes. We're going to have to do approval of two different sets of minutes. The first being the September 16th Financial Subcommittee meeting minutes. So again, I'm going to be asking Financial Subcommittee members to please review these minutes, and we'll entertain a motion to approve those when you are ready.
This is Stephen. Make a motion to approve.
Good morning, Stephen, and thank you. Do we have a second?
This is Bert. I'll second.
Thank you, Bert. All right, all financial subcommittee members, I'm sorry, any discussion on those minutes? Hearing none, those that are in favor of approving those minutes, please respond by saying yes.
Aye.
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 Do we have any financial subcommittee members opposed to approval of the September 16th minutes?
Faith, this is Kylie. If I wasn't present, since I'm taking over from Jeanette, should I just abstain?
Kylie, I would recommend that yes, you abstain. Thank you.
Hi, this is Lori. I abstain. I was not present in that meeting.
Thank you, Lori. And all right. And I think then that anyone else abstaining? Okay. All right, then we are going to move next to the October 21st Health Policy and Planning Subcommittee meeting minutes. And again, I would just ask Health Policy and Planning Subcommittee members to please review these minutes. We'll entertain a motion when you're ready.
Hey, this is Bert. I'll move to approve.
Thank you, Bert. Do we have a second?
Yeah, Bill Oberly, I'll second.
Thank you, Bill. Any discussion of the minutes? Great. Those in favor of approval, please respond by saying aye. Aye.
Aye.
Aye.
Any members opposed? And any members abstaining?
This is Matt. I abstain.
Thank you, Matt. All right. I think that wraps up our minutes. Appreciate everyone's review of those. We'll move quickly into director's report. I can be very brief this morning. As I mentioned in my opening comments, much of the items on today's agenda we will be bringing before the full SEBC when they meet next Monday, the 25th. That meeting is scheduled for 2 p.m. Due to the number of agenda items, we have extended that meeting till 4:30. Correct. Okay, so that meeting will be from 2 to 4:30 next Monday, the 25th. And then, as I did mention last month, we have been able to schedule a retiree healthcare benefits advisory subcommittee meeting. That is today, the 18th, from 2 to 3 p.m. That will be virtual as well as in person here at the statewide benefits offices at the Department of Human Resources. So we are trying to wrap up at least remaining open items that we have with the subcommittees and obviously the SEBC, recognizing we will have some changes in committee composition and membership as we transition into the new year. So with that said, I don't know that there will be subcommittee meetings scheduled for December. I think a lot of that's largely going to depend on today's discussion and any requests from subcommittee members, again, as we try to wrap up work and prepare for the transition. So any questions before we jump into financials this morning? Right. And then just if I could, before I hand over to the Willis Towers Watson team, Brian Stitzel would typically review the financial items with the subcommittee members. Brian, due to an expected family emergency, is not able to join us today. So Kant Katari from Willis Towers Watson will be reviewing the reports and providing the updates this morning. So I will hand it over to the Towers team. Good morning, Kant, Jacqueline.
Good morning, Faith. Good morning, members.
I think, Jacqueline, you don't have anything specific to add. I can take over and start going through the financial summary deck.
Sounds great.
Just for
Thanks.
just for the benefit of everyone on the call, the September deck wanted to make sure we added that into this update with the October. So there will be two exhibits here, September and October, for a couple of the slides. So just starting off, we have our executive summary of September, and notice a similar thing happening both months where the overall total is better. Just starting off at the line item level in September, something we see in October too, just the lower than expected state employee premiums caused that difference. And then on the claim side, what we noticed in September was there was just one less invoice compared to expected. That's why that was causing, in terms of the reporting, the difference, leading to that 1.5 for September, which obviously we're 31 days past that. And if we could go over to the next slide in October, I'll just quickly provide some comments on October and then pause for any questions. If we could quickly flip to October. I keep looking at the one screen. So in October, just kind of staying on the premium contributions and something similar where lower than expected state employee premiums caused that difference. The claim story on October was a little bit different. It was better off just due to the budget non-Medicare rates, and the higher Medicare rates were offsetting it slightly, but not enough to kind of drive the difference. And we also had a $600,000 CVS credit that we put into expenses for October, which was the one update. So I wanted to just make sure I teed off the September versus October executive summary story and differences. Any questions on that before the next slide? Great. Next, we have a forecast just detailing the months and how the overall surplus after reserves is affected. Obviously, September's included, and then we have October with the reforecast data and just kind of showing the same trend happening both months, leading to a October reforecasted of surplus of 45 after reserves on the budgeted side, but on the reforecast at the bottom, it's at 42.4 October. I know that a lot of the comments do come on some of the individual subtopics of these graphs, so I can move on to the premium contributions, which I know we can talk a little bit more detail, and I can draw back to my comments from earlier, but just to reorient the group, we have our budget and our actuals, and the two black highlighted rows are the September and October data. And just to make sure the comments from the executive summaries jive, this is where you would see the difference in the state level employee premiums on the budget versus expected, driving the differences over there. And I know that the contributions and the other revenues really make up the two main pieces of that, and there's the claims. But any questions on the contributions piece before we move on to the other three? We can move on to the other revenues. Just wanted to call out that this slide, similar to the prior one, we're just bucketing next to each other and showing the differences that we had over there. I think the only major call out for October was the difference in the CVS coverage gap discount. That caused if you look at the fourth column from the right, the 7.54 million at the top versus the 7.864. That was definitely one of the bigger drivers in other revenues this month. And after that, we really like to get into the claims and talk about the other end of things, which once again, just going back to the earlier comments, we saw that in October, we did well on the non-Medicare side, and on the active side, relative to budget, kind of causing that better off ratio for claims. So that's really the story really happening through October. We additionally have some GLP-1 exhibits, but before we get to that, any final questions on the premiums, claims, contributions? Want to make sure I cover all the bases. Great. Then on the GLP-1 slide, we're basically showing 2 additional months, September, October, of data that has been pulled in for the weight loss and the anti-diabetic drugs. As you can see, the overall relative to budget, the green versus the tan, maroon at the top, slightly lower, 1.3 million on the weight loss, 400,000 on the anti-diabetic. We are seeing the numbers start to tick up at around October in the red, but it's still below budget that we have at the top. So just something to experience and monitor on GLP-1s, which is related to the next slide. Something we actually put together, CVS sent over, kind of going over the, call it the pipeline for GLP-1 drug expansion. As you can see, just with all the various details and exhibits on the slide, it's very robust. There's increase in utilization and spending, and a variety of different items affecting that. And we wanted to make sure we include that information on this slide. So if there's any questions once everyone has a chance to review and there are any follow-ups, we'd be more than happy to take them or follow up with CVS.
This is Stephen, and I can't, I'm on the phone today, so I can't see the exhibit, so I apologize, but I do have a question.
Mhm.
You mentioned utilization increase. Is there something that displays the number of employees utilizing it and the price per unit? I'm trying to figure out if the cost is going down, but it's still being utilized more, the relationship between utilization and price.
The car thing. The slide before has the GLP-1 data, which is just based on claims we get, and then the dollars. It doesn't specifically come from the number of employees utilizing. So if that's something, we can take that back and look into that. The data itself is broken out at that level, and the slide after that was more so a figurative illustration of GLP-1 factors
So
in
has
the
there
current
been any?
environment.
Yeah, I get that. I should have known that. But it's claims based. Is there any sense of price along, in the last 6 months? Is it remaining the same, or are the costs remaining the same, or is it coming down? Anything informative in terms of that issue?
Yeah. Do you mean just generally in the industry and trend for GLP-1 drugs, or specific to the state and the employee spend, or both?
Just our cost.
Yeah,
I've heard a lot of story on rebates, and I don't want to confuse it because of the rebate issue. But just the gross cost of the drug, is it changing in any direction?
Yeah, I think there's a couple different ways we could address that and answer it. Could I have your name repeated one more time?
If you don't have the answer right now,
Steven?
I don't need the answer
Yeah.
right now. I just, I get that. So it's just something I'd be curious to see.
Yeah,
Steven.
absolutely. And I'm making a note of
Yeah,
it.
My apologies. This is Colleen Davis. I would just agree with Stephen that, going forward, that kind of information is actually what's really, really valuable. I would say not to speak for everyone in this committee, but that information is valuable. So having it on a consistent basis would be very helpful.
So even taking like the kind of 12 months, but maybe seeing some prior history, then being able to just see in the exhibits themselves what those are. Okay.
This is Stephanie Hardis from SBO. I can jump in. The cost per unit has not been changing over the past months and year that we've had this program in place. The increase that we are seeing in spend is vastly driven by utilization. We aren't really seeing any variation in the cost of the drug.
Has the rebates on the drug changed, aligning that with, if we get to the rebate side, and I know we've had some earlier discussions on this, have rebates increased? I guess we're just trying to figure out a trend, because if there's any potential policy decisions around this, I think it's important to have basically more granular display of utilization and cost.
Sure, Stephen. So unfortunately, we don't receive rebates on the claim level, and we don't receive any rebate information by individual drugs. So
I know you don't receive it by drug, but you receive it by class. Okay. So you can get rebate information on the class of drug. GPL-1s is one class of drugs, right? You can't get individual, drug rebate, like the brand name of the drug, and get a rebate amount on it. You can't get that.
That is, we did share that information with the SEBC in executive session. I believe it was in September, and CBS has agreed to allow us to share that in executive session with the SEBC annually going forward. Unfortunately, we don't have any information to share in the public session at this time.
That's very interesting, because usually class rates by class is pretty much a common number that's given out, but I get it.
Thank you. And Stephanie, I'm sure I can follow up with you if you have any additional items along that you want me to look into for GLP-1. We can, if there are any other questions. If not, I think towards the end we have the expenses broken out over here. I think the main kind of call out, just as I was saying from the earlier executive summary slide, the October had the $600,000 credit for CVS, put it there. So just wanted to mention that as we were on the exhibits, on the expenses. But besides that, it's just full comments for those 4 items, and then we'll move on to the fund reports. Just for the sake of filling it out, we have September and October here. So this was the September health fund report. This would be the October. Next, we can move on to the long-term projections, where we're taking, before we move on to the specific long-term projections, we're just going to talk about, or make sure the group recenters around the rating approaches, which I'm sure some of this stuff, a lot of you have heard a lot of times, but just to make sure for the sake of the group, we have a methodology where the risk is spread across the largest group. There's this dynamic of active versus retired, and the claim experience that they will have, and the overall utilization according to that. In addition to that, the non-Medicare versus Medicare, and then just separating it by these various cohorts. And based on that, we've taken the data, taken the experience, have the groups in this table up to the right, where the specific percentages are updated each month based on the latest data showcasing what that rate action would be. And I know we'll be talking more about this later, but any other specific questions on the rating approaches before we get to the actual long-term projections by group? Great. then I think we'll start off with the overall LTP, all combined, and just the center column projected FY25 is the one we're currently in with the 27% rate increase. And this will obviously match up to a lot of the comments I made on what happened through October, but just wanted to call out that the next rate actions for 26, 27, 28, static one to get back to that zero reserve surplus deposit would be 4.2% for all groups combined. And we have some additional assumptions on the right if anyone has specific questions about what goes into them. But the next one would then break this entire all GHP into the active cohort, which once again, you're going to see slightly different percentages and increases to get back to that zero for the display here. And on the case of actives, it's 4.7, a little bit more than the 4.2 we saw for the whole thing, because we need to get them a little bit higher to get them back to the zero surplus. Then if you go to the next two, we have pre-65s, significantly higher, it's much smaller group, much higher volatility. To once again, just mathematically, if we split them out, did a rating action to them, that's the way to get back to the $0 surplus. Any questions? Because then the final one would really be the Medicare, kind of showing just based on what's set in place, 27% for the 1 year, and kind of what the final outcome would that be to the surplus in FY28. And this would just end up mimicking and matching the executive summaries for the full year on down to the 28. That's the majority of the updates for October. The rest, we have more updates on the rates and a few plan design items. So I think the first slide is really just kind of laying out the plan designs where the current state is across the 4 plans, Gold, HMO, PPO, Basic, and just on the right, what the standard medallions would be for these plans. Just as we've seen costs go up and there's so many discussions around rate action and making sure that the plans are well aligned, having this here and then going into the next slide, which really shows the rate action by a 5% rate action, which would be the first set of purple table numbers, or if we ended up aligning those AVs for the rates, then what would be the rate action? We wanted to display that to the state and update with the experience through October as usual. So that's what the FY26 rates would be. And then the actual plan designs on the next few slides would really talk about for each of the plans, seeing in the purple on the right side, the differences. So anything in purple is changing from the left. And then the main number at the bottom, the change in actuarial value, 92.6 to 90.5 for the first state basic, just highlighting the magnitude of the impact these changes would make if we decided to look at or start exploring those plan design options. And we have this available for the first state basic, and then for the rest of the 3 plans, as you can see. You can skip through those or tab through them, not skip through, Jacqueline. CDH Gold. This one has funding, so there's going to be 2 AVs at the bottom, and then the HMO, and finally the PPO.
And is it also fair to say too that the intent of the couple of slides on the plan design information is really just to bring to life what potential plan design changes could look like in order to track back to a change in the actuarial value or the AV. So, yep. This certainly isn't set in stone. This certainly is not, the only potential design changes that could be considered in order to get back to, the specified actuarial values. But again, wanted to put a finer point on it for the subcommittee. Yeah.
The right first step to getting back.
Yeah.
Actually.
Jacqueline, this is Faith, just to piggyback off that for subcommittee members. This was requested by the full committee when they met last month, was to get a little bit better understanding of what these potential options would look like in terms of impact to both the member and the state as the employer.
Thank you. The rest is appendix. So I would just ask the group if there's any questions for me on the financials presented here. If not, I believe there's one more quarterly financial report we would like to go through as well for the group.
Actually, this is Bert Scoletti. Just I do have a question back on the plan design slides. Are those at existing contribution levels? Employee contribution levels? So we're keeping the contribution levels the same and adjusting the plans, right?
Yeah, that would be keeping it just the plan design changes.
Okay. Thank you.
I think we're good to move on to the financial reporting Q1. A same amount of slides is actually the deck we just saw, but definitely not planning to spend time through all of them. I think just want to focus on the first two. The first table here is showcasing the quarterly costs from July through September for this year and for last year, and just seeing the net difference. I don't have to be the first person to tell the group here the reporting differences of the vendor invoices, which get flown in through the reporting versus, the invoices versus the vendor reports. And this data is through September, so just wanted to call that out. But with that experience, we were looking at a 95% loss ratio through vendor reporting, which I think, looking back at Brian's comments on the September fund report, it was basically saying we were missing that one payment, so it was right below it, which tracks up to that 95%. And that's really for the entire group broken out. And then just below that, if you want to scroll down a bit, we'd like to have the last table has the actual cost broken out by vendor at the high mark, in case you wanted to see the breakout that way. But it's really just that quarterly before, after, what the difference is. And at a summary level, this will let you know what the quarter is tracking to. And the additional notes I just want to mention a little bit, Jacqueline, where for the group, we want to make sure the rates for 25, they have the 27% increase reflected, what's happening with the expenses and kind of how the HRA dollars are being factored in. Just a few different additional items that would go into the numbers here. I wanted to call that out. And one difference we'll notice this time, and I wanted to ask the group, was previously when we did provide the key trends reporting, we would take information from there and include it in this report as a part of the whole package. I know as of last month that isn't happening anymore, so we opted to remove from here. Would that be the case going forward, or would you like us to add those summary details back in? And we can discuss this at another time, but I wanted to just put that on everyone's radar. And I would like to talk a little bit about the next page, which is breaking out at a more detailed level the first quarter, starting at the top, the total program costs, breaking it down to the fees, the expenses, the contributions, and then further down at the bottom, we have the PEPYs. And one thing we like to do is just compare to Q1 24. So something we like to track with the vendor reporting, and this is the main page that has the data on it, with the rightmost column having the delta difference. The first quarter, as you saw through September, was at that 95%, but we've already had another month of October, and pretty soon we'll be working on the next quarter's version of this report. Any questions on the quarterly report? Great, thank you. If there are any questions or follow-ups, please feel free to email me.
Great, Jacqueline. I think we're ready to move on to the key trends analysis, which we have Walt here who will be presenting. Walt is one of our consultants through our data analytics Meredith contract. So Walt will be walking through the key trends report, as well as the site of steerage and the diabetes dashboard.
Are you going to drive the slides or?
Jacqueline is presenting the slides.
Okay, so you go to the next slide. This kind of goes over the key observations, but I'll walk you to the slides where talking about the stuff. So if you go to the next slide, this just shows that the overall allowed amount, and this is paid claims from October through September. So the overall allowed amount increased by 10.5%. Net payments went up by about 9.9%. So you're over $1 billion. And this is active employees and early retirees. It excludes the Medicare population. If you go to the next slide, you'll see that 10% is largely driven by a 20% increase in prescription drugs. There was a smaller increase in outpatient medical services of about 5.6%, and then inpatient medical services were about even. It went up slightly, about a little bit less than 1%. You go to the next slide. This basically shows that overall your members increased by about 2.2%. So you had an increase in your population, and of that, your employees went up by about 3.1%. Go to the next slide. I think the only thing I wanted to call out here was that radiology went up by 11.5% on a PMPY basis, and mental health and substance abuse services also went up, and prescription drugs. Go to the next slide. Here in the next slide after this. Go to the next slide after that. So, like I said, inpatient medical costs did not increase that much, but you'll see that the allowed amount for medical admissions increased, both for allowed amount and net pay. Yeah, 10% decrease in admissions for surgical services and a smaller decrease for maternity services. But overall, if you go to the next slide, I think it's on, you'll see that it's not on this slide, but I wanted to mention that average length of stay, I think, went up, and the average cost per admission actually went up. So admissions per member per year, facility, not much of a change on allowed amount, not much of a change on professional services as well. Go to the next slide. This is where you see the change in allowed amount for medical and maternity. So although admissions went down, the cost went up. Go to the next slide. Go to the next slide after this. Just shows you the change in allowed amount per member per year and patients for various service categories. You'll see that substance abuse again is a driver. Major procedures, especially drugs on the medical side. I think that's all I want to say on that slide. If you go to the next slide after this. The next slide after this. This breaks out office visits by specialist visits and non-specialist visits, and the top specialty providers as well. Visits and allowed amount per visit. Go to the next slide, 16. This is where you see the radiology, which really driving the increase in radiology allowed amounts, nuclear medicine and therapeutic medicine. And what's really in there is, and PET scans to a smaller extent, but what's really in the nuclear and therapeutic is radiation therapy. So it's a lot of cancer being treated. You go to the next slide. Lab services, the main takeaway here is microbiology actually had a huge decrease, and this is where the COVID tests are. And so decrease in COVID tests is leading to kind of mitigating any kind of increase in laboratory utilization and cost. Go to the next slide. So for pharmacy, you'll see specialty drugs went up by 14.1% on allowed amount per member per year basis. Overall, it was 20.7% on a per member per year basis. You'll see the allowed amount per day supply went up. So on the non-specialty drugs, there's definitely an increase in cost. On the specialty drugs, the allowed amount per day supply only went up by about 2.1%. So if you go to the next slide, this breaks out the top therapeutic classes for non-specialty drugs. You go to the next slide. This breaks out your top drugs for specialty drugs, and you'll see that on the medical side, there was a 17.4% increase, and on the prescription side, there was a 16.6% increase in allowed amount. So on both sides of the coin, go to the next slide. This is the top 15 drugs through the, especially drugs through the prescription plan. Number of patients. Go to the next slide. This shows the mental health, and you'll see that the mental health is both the increase in the mental health and substance abuse is both on the inpatient and outpatient side. Go to the next slide. With preventive visits, it went down slightly for well child visits, but went up for well baby and preventive visits for adults. And on the screening side, you had increases in colon cancer screening, colorectal screening, and cholesterol screening, and a slight decrease in mammogram screening. And if you go to the next slide, you'll see that breast cancer had a 31.4% increase in allowed amount per patient. So that's the big one. The other big one was both in terms of the relative increase and the absolute increase in terms of dollars. Cerebrovascular disease was also a pretty big jump. And if you go to the final slide, this is based on incurred claims experience for FY24. So this shows you your risk profile for your active and early population. You'll see that a lot of the costs, about 3/4 of your costs, are actually in the struggling and in crisis groups. But it's a very small percentage of the overall population. If you look at, it's not on here, but if you look at the risk score compared to last year for this population, it went up slightly as well. So they got slightly sicker than they were last year. And if you go to the final slide, it kind of gives you some definitions on how these groups are defined. Are there any questions on the key trend report?
Hey, Walt, this is Bert Scaletti. The specialty drugs numbers, are those numbers, do not include, I guess, the money coming back from Prudent RX, if I recall correctly?
It does get factored into the overall. Yeah, we've got a calculation that factors that in.
Okay, so those numbers are net of the Prudent RX money coming back.
Right.
Okay, thank you.
So if there's no other questions on the key trends, I guess we can go to the site of service report. Not a lot to report here, but there is some good news here. If you go to the visits to emergency rooms, slide 4, yeah. So you'll see overall allowed amount went up and visits went up for non-emergent and primary care visits. The biggest increase in those visits were in urgent care. So that's good that even though visits went up, more people are going to urgent care than the emergency room. And if you go to the next slide and the slide after that, and the next slide after that, the good news here is that down in the bottom right, you'll see that your ER visit ratio, your urgent care to ER visit ratio actually increased from 4.2 urgent care to ER visits to 4.9. So more people are going to the urgent care. If you go to the next slide, these slides just break out what's going on with particular diagnostic summary groups and whether they're increasing or decreasing at certain places. If you go to the next slide, and next slide after this, next two slides with the yellow are kind of looking at whether people are migrating from urgent care to primary care or primary care to urgent care. If you go to the next slide, the slide after that, and the slide after that. This is telehealth. Telehealth visits. You can see Teledoc, Amwell, and all other providers. So for visits and for net payment per visits. Go to the next slide. This just breaks it out graphically. Go to the next slide. This is the high-tech radiology. Again, this was one of the drivers of overall increases. And here is kind of an opposite story from the ER urgent care. More people are going to hospitals for high-tech radiology than freestanding facilities. The increases are higher at the hospitals, and the allowed amount is higher at the hospitals as well. You go to the next slide. Actually, just go to slide 24, I think. Yeah, the only other thing I wanted to point out on site of service is slide 24. This breaks out your top outpatient surgeries or events by ambulatory surgery centers and hospitals, and it also gives you some average cost differences. So you'll see, for example, for a colonoscopy, it's about $3,300 cheaper to have it done in an ambulatory surgery center than a hospital. For down there at the bottom for a tonsillectomy, it's $6,600 cheaper to have it done in an ambulatory surgery center than a hospital. So just wanted to point that out. That's all I really wanted to say about the site of service report. Are there any questions about this, any of these?
Not a question, but confirmation. So, well, you said the high-tech imaging services at hospitals actually went up as a percentage of those visits as compared to outpatient, right?
Yeah, they went up at a higher rate, and the allowed amount went up at a much higher rate than freestanding facilities.
Okay, so probably something we want to look at when we're designing rates for next year, in terms of steerage rates.
Paul, is there a way to break out that utilization in any way by preventive versus diagnostic at those sites?
You talking about the colonoscopies?
I'm just talking about the radiology in general.
I can get down to the procedure level. Yeah, I can do that.
I mean, I'm just wondering if some of this is being driven by the severity or the diagnosis of, whatever is causing the need for the radiology, and there's is more utilization going through the hospitals because it's more complex or a need than.
And some of the stuff was, like I said, a lot of it was on this report. I limited to, well, anyway, yeah. If you look at the therapy, so the therapeutic radiology and nuclear medicine. Mm-hmm. So that's a lot of cancer, and that's what I mentioned before, that a lot of that was driving that increase. So yeah, so that makes sense. But yeah, I can actually get more granular than that.
Yeah, because I'm just thinking we might want to be careful. I agree with Bert's suggestion, but I think we want to be mindful of what services people are getting and why, because that could be driving the site in which they're choosing or being referred to by their physician.
Want to go to diabetes now? So we've been working on a dashboard for diabetes as it's one of the strategic initiatives for the GHIP. This is limited to the active employees, spouses, and their dependents. And I think our intent's to do this twice a year going forward, because we can do it on a calendar year basis, on a fiscal year basis. And we can also get new risk scores every 6 months. That kind of is one of the displays on this. But so this is fiscal year 24 data, incurred claims. And on the top left is the prevalence and total cost of diabetes. So you'll see the prevalence went up from the prior fiscal year. The cost went up as well. And you can see that it's also broken out by whether it's the employee population, the spouses, or the children and dependents. The two bar charts next to that, the risk score and trend comparison, looks at the overall risk score for diabetics compared to non-diabetics, compared to the total active population, and also compared to the book of business norm. So we have that for the risk score, and we have that for allowed amount per member per year as well. So you'll see for diabetics, for example, in FY24, the allowed amount per member per year was about $23,000 compared to about $9,000 for the overall active population. To the right of that is the impact within a population. So you'll see pre-diabetes is the first set of bars. Type 1 diabetes is the second set of bars, and then type 2 diabetes is that third set of bars on the top right-hand side. Below that is the impact to patient cost and count, where you see the percent of the total patient population with diabetes is about 10%. And this excludes, the only place that pre-diabetes is brought up is in that one chart in the top right. The rest of it is really limited to diabetes. So about 10% of the patients in the active population have a diagnosis of diabetes. They're accounting for about 32% of the total drug cost for actives in FY24, and they're about 24% of the total medical and drug cost. So about a third of the drug cost and about a quarter of the overall medical and drug costs for this population. If you go down to the next section, you'll see the percent of diabetic episodes, and we use a disease staging methodology. So this is looking at different stages of diabetes, and the idea is that it's a continuum. The higher you go, the worse it is. Stage 4 being death, which is not shown on here, but so stage 1, you can kind of think of this as uncomplicated or well-managed diabetes. So about 52% of the population is falling into that category. Stage 2 is kind of local complications or minimal complications. For diabetes, it's stuff like, mild neuropathy, that type of thing in stage 2. And then stage 3 is multiple or systemic systemic complications, and includes things like kidney failure in that group. But so you'll see only about 3% of the populations fall into that. But when you look at the cost by stage, you'll see for stage 1, it's about $4,000 per episode. By the time you get up to stage 3, it's well over $20,000 per episode of care for diabetics in that stage. To the right of that, we look at, and this chart on disease staging and department group, it's largely a function of the population size, but just wanted to point out you do have a slightly different distribution of patients in different stages in different departments. So you'll see in DHSS, for example, you have more people not in stage 1 than the other departments. And it's probably age driven, but just to point that out. If you go down to the next set of charts, we have a number of quality measures in the claims database that are based on HEDIS specifications, and we group those. And we have an endocrine group, which includes these measures you see here: diabetes blood pressure control, diabetes eye exam, kidney health evaluation for patients with diabetes, etc. And we kind of did an overall score based on the overall numerator and denominator for these different measures. And you'll see the overall score didn't really change that much. It's 44% in FY23 and 44% in FY24. You're doing better than the norm on most of these measures, the exception being diabetes blood pressure control. We can discuss at some other time whether how well populated this measure is, but, and then also similarly with the diabetes eye exam, we have complementary information available from iMed that's not kind of included in this dashboard. So I would suspect that a lot of the diabetics are getting their eye exams through their eye benefits rather than their medical benefits. And then to the right of that, kind of the similar idea what we did above, we take the top 5 locations or departments or agencies, if you want to think of it that way, in terms of their scores on these quality measures, and then the bottom 5, with the idea that maybe you want to focus on the bottom 5, doing some type of outreach. If you go down to the next page, this looks at utilization of services on the top left among diabetics and non-diabetics for admits, days, the length of service, the length of stay, the visits per 1,000 to the ER, the preventive visits for adults, the outpatient professional visits, and the day supply per patient. And that includes all medications, not just diabetic medications. To the right of that is the utilization of services specific to diabetes care, comparing members with diabetes to members without diabetes by service class, by service category, basically. And we look at allowed amount, the percent of total diabetes spend, the patients, the total patients, the percent of total patients, the allowed amount per patient, and the out-of-pocket per patient. Below that is RX spending utilization by anti-diabetic class. This doesn't get to the whole pricing question, but it does address it around the edges a little bit. So we have the therapeutic classes for diabetes drugs, and we also throw in the GLP weight loss drugs here as well. And you'll see the day supply per patient last year compared to this year, or FY23 compared to FY24, the net payment per member per year. And then you see that 60,000% increase for weight loss drugs because they weren't covered prior to FY24. And then over to the right is the top 10 drugs for diabetes patients for allowed amount and the day supply allowed amount and the allowed amount per patient. Go down to the next page, I think. Oh, these are just some trend charts for the last 8 quarters showing, again, the therapeutic classes for the number of scripts and for the total net spend by therapeutic class. So if you look real close, the dotted black line is your weight loss drugs. The green line on the top for the total net spend is your diabetic GLP-1s. You go down to the next slide. This is a little bit complicated, but we broke the population out by 3 groups. We did type 2 diabetes patients with at least 1 GLP-1 prescription. Then we looked at a group of patients with at least 270 days supply of GLP-1s in each of the time periods that are listed here. And that's actually a subset of that first group. So the first 2 groups are not mutually exclusive, but the second group has at least a 270-day supply. And then the third group is those diabetics that do not have a GLP-1 drug. And that group is mutually exclusive from the first 2 groups. And we look at the number of patients, the medical allowed amount, the prescription allowed amount, the total allowed amount, the day supply. I thought what was interesting here is you'll see for medical spend in the latest year, patients with a 270-day supply actually have a lower medical spend. They have a higher prescription spend. So the medical spend savings kind of is being eaten up by the prescription drug savings. But if you want actual outcomes, the percentage of diabetics with at least 1 flare-up is lower for the group with 270-day supply. So 2.1% of the patients with at least 1 GLP-1 drug had a flare-up during the year. Only 1.5% of the members with a 270-day supply had a flare-up, and almost 3% of those without a GLP-1 drug had a flare-up during the year. And if you go down to the final set of charts, this is we looked at the risk profiling in the key trends report. This is looking at those highest 2 groups. in terms of your disease management or care management programs for Aetna and Highmark. So you'll see over on the left, this is the members with diabetes, the percent of members with diabetes that are showing up in any of these interventions that Highmark and Aetna are offering. So about 5.9% of the Aetna diabetics, or 5.3% in the latest year, and about 16.8% of the Highmark diabetics in the latest year, which was a huge increase over the prior year. So they did something in FY24 to get more people in. And then we kind of took a subset of those patients and looked at those that were struggling or in crisis. And we looked at the number of patients that were in that category, the number that were identified by Aetna or Highmark, and then the number that were actually engaged by Aetna or Highmark during the year. And that's the final set of charts. And I think that's it for the diabetes dashboard. Are there any questions on this or comments?
I just have two comments. One being, if I understood what we're sort of reviewing here, it sounds as though we have had a slight uptick in, I believe you called it cerebral vascular incidents that resulted in inpatient care.
No, with clinical conditions, we look breast cancer and cerebrovascular incidents were two of the leading clinical conditions that were contributing to the overall increase in allowed amount. I didn't really break it out by inpatient or outpatient, but
Okay, yeah. I'm curious as to whether or not some of the crossover of, diabetic management and blood pressure control, if there may be some congruence there. And obviously it's a speculation, but there could be a correlation depending on whether or not there is concomitant disease in those groups of individuals that we're seeing that increase with. The only other comment that I have is that I have anecdotally heard from a couple of state retirees, and they are describing a challenge with filling their medications, particularly their specialty medications. And those are things that, as many of you on the board know, those are medications that stabilize their condition, and not getting those medications can result in hospitalization and really substantially poor outcomes and much higher cost. And so I just want to keep us kind of aware of that. And I'm just curious as to whether or not there's a method for ensuring that that doesn't happen. Because again, I've heard from several state employees and retirees who are having challenges with getting their specialty medications more recently. And I think, sorry, one other thing that I thought about as we were going through this is just kind of around, you sort of broke out which areas we're seeing state employees, have a harder time. I don't know how else, like, what we don't want to necessarily kind of dig into the why behind why individuals aren't receiving their preventative care. But I guess my question is more for the SBO team in, your ability to help sort of target those agencies specifically that maybe are having greater drop off in folks pursuing preventative care. So that's all.
This is Faith Rents. Thank you. If I could, with regards to your comment about concerns from retirees about specialty medications, there's a lot of factors behind, what could be driving those concerns. So I'd hesitate to say there is any one particular challenge that might be causing those concerns. I really think it's important that, to the extent you're hearing those directly from retirees, that they understand that it's really important for them to engage with our office, so that we can research, figure out, what really is truly causing those problems. And to the extent that we identify trends, certainly we'll bring those back for discussion with this group. And then specific to the targeting of agencies around preventive care, we will actually be releasing scorecards for all of the agencies on just demographic and adherence data for their populations. We'll be doing that early next year, and it's an opportunity for us really to engage in discussions with agency leadership around, what their employee and covered lives, how they're utilizing their benefits in areas where we see gaps in care or adherence, and preventive care is just one of those factors. So I just want to put that out there. I mean, that's something we're really hoping with the new administration that we'll be able to engage with incoming agency leadership and introduce them to those scorecards, and open a dialogue about how we can partner to help promote the areas that we see in the scorecard that perhaps could be improved upon with just better education and targeted communications to their population.
Jacqueline, I think that the next item is with me, the reciprocity health presentation. All right, great. Thank you. Good morning, subcommittee members. My name is Stephanie Hardis. I'm the SEBC and subcommittee manager, and I'll be presenting today a follow-up to the reciprocity health therapy presentation, which was presented in October by Dr. Cindy Teal, representative of Reciprocity Health. So what was presented in October was a pilot opportunity for group health insurance plan members who are active employees of the state and are enrolled in a Highmark non-Medicare health plan. There were a few follow-ups and additional opportunities that we would like to walk through today. And at the end of the presentation, we'll be requesting a recommendation from the subcommittee on whether to move forward and which pathway you would recommend moving forward. So next slide, please, Jacqueline. So just a quick recap from the October subcommittee meeting. Reciprocity Health, which is an established partner of Highmark Delaware, proposed an incentive-based diabetes prevention program for Highmark non-Medicare members who are active state employees and are considered pre-diabetic or at risk of developing type 2 diabetes. This program would align with the current YMCA diabetes prevention program that is offered to group health insurance plan members, and would provide enrollees with incentives as they work through the YMCA program to encourage attendance and improve program and personal outcomes. Financial incentives that would be included in this initiative would be cash incentives for things like attending meetings, whether that be in person or virtually, completing food and exercise logs, health surveys, and more, which we'll go through in the next few slides. As a reminder, these incentives are provided on a reloadable debit card by Reciprocity Health and would be considered taxable, which is why, unfortunately, we have to limit it to active employees for this pilot. And as also a reminder, funding for this pilot of up to $70,000 has already been secured through the established Highmark Communications budget, so there would be no additional cost to the GHIP for initiating this pilot. Next slide. So one of the requests from the subcommittee at the last meeting was to see a proposed timeline, or in this instance, we have multiple timelines for what this program would look like. The timeline that you're seeing here on your screen is based on metrics that we currently receive from the YMCA for their diabetes prevention program. The second option, which you'll see in just a moment, is more enhanced. So In this sample, what we're looking at is a 12-month program which matches the YMCA Diabetes Prevention Program and has a maximum cash incentive of $245 per enrollee. As detailed in the proposal, you can see there's a step-by-step process through the weeks and months of this 12-month program. Members would receive a $5 incentive for each YMCA meeting that they would attend, as well as a $3 incentive for submitting their weekly food logs. So the food logs, and you'll see this actually in the second option as well, the exercise logs are already a part of the YMCA Diabetes Prevention Program. But when meeting with the YMCA, reciprocity was informed that enrollees tend to not turn in their logs, or at least not turn in completed logs regularly. So they had actually requested that that be something we include in our incentives to really encourage members to complete those logs and really participate more actively in the program. This option on your screen currently, as you can see at the end, members will be eligible to receive certain cash incentives based on percentage of weight lost. We do have an alternative to that in the second option. But before I move to that option, also just wanted to note the program feedback surveys as well as the baseline survey. Those would be immediate cash incentives that the member would receive by completing the survey on their app. However, the incentives for attending group meetings and turning in the food logs, unfortunately, those would only be awarded on a monthly basis. The reason for that being is we only receive YMCA reporting on a monthly basis. Reciprocity did try to work with them to get increased reporting, but unfortunately, they just don't have the administrative report to increase that level of reporting. So those would be received on the reloadable debit card on a monthly basis. So before I move on to the second option, which would be a little more enhanced, does anyone have any questions on this specific timeline? Let's show the next slide, please. Thank you. So again, this is a more enhanced version that allows members the opportunity for more engagement, which would also result in more incentives. As you can see, this option is up to $275 per person. One of the main issues we wanted to address in this option is the drop off that these programs, and specifically the YMCA DPP program, tends to see. So nationally, DPP adherence for the YMCA is about at 50%, which is similar to what we see in our population. So 25% of people who enroll in the YMCA DPP never attend any sessions. 65% approximately actually dropped out before month 4. And for those who do complete the full 12 months, which is 25 total sessions, on average, they're only actually attending 16 of those 25 sessions. So that's an issue that we really wanted to address, was to ensure that people who are enrolled in this program are actively attending those meetings on a regular basis. So this option addresses that specific issue by increasing the incentive the further you get into the program. So as you can see on the left-hand side, for the first 4 months where the meetings are on a weekly basis, members will be receiving a $3 incentive per meeting, as well as an optional additional $2 of incentives for those meetings for submitting those food and exercise logs. However, as you move forward and continue on with the program, you're incentivized more for attending those meetings, which would hopefully keep people in for the full 12 months. So for months 4 to 6, the meetings switch from weekly to bi-weekly. So members could receive a $10 incentive for attending those meetings. And then months 6 to 12, the meetings are on a monthly basis. And again, a higher incentive of $15 per meeting to incentivize members to fully complete the program and not see that initial drop off in the first few months, which we tend to see. Also in this option, instead of having bonuses at the end, as we saw in option 1 for percentage of weight lost, members have 3 opportunities throughout the year to receive bonuses for attending the majority of their sessions. We also learned from the YMCA that they are working on ways to offer makeup sessions for their enrollees. So say someone misses a class for an unforeseen circumstance, typically the way it's currently structured, they would just miss that class, and any type of education or learning that's being provided, whether that's nutrition education and counseling, maybe exercise class. Typically, those would just be missed. But they are working on ways for the members to make up those missed classes if they choose. So that would also be enrolled into this. If a member were to miss a class and they have a chance to make it up before that bonus deadline, they could still be eligible for the bonus. So just comparing the two options a moment, and specifically looking at the bonus structure, I think we would see more success and adherence with these specific options as opposed to weight loss at the end of the program. Retrospective reviews of other programs have shown that that's typically the case, where if a member would have to wait 12 months to get a bonus for losing 5% of their body weight, it may not be enough of an incentive to really keep them actively attending. Whereas if they know they're getting regular bonuses for attending the sessions and really getting all that information, we would see that that would typically keep them in the program and really keep them actively engaging much longer. Any questions on this sample timeline here?
I don't have a question. I just want to commend everyone for putting such substantial thought into ensuring that this was a meaningful rewards program, and I just want to thank you all.
We can move to the next slide. So this is, we're really looking into the cost and the pilot size. So as a reminder, we have 3,200 members who are active employees in the Highmark plan who are considered pre-diabetic. So that's 3,200 members who would be eligible for this program. And the cost estimate that we presented at the last meeting in October, that was for a 50-person pilot. Noting, of course, that we have such a large population that is eligible and that there are significant incentives to this program. We wanted to provide an opportunity to expand that pilot, noting again that we have up to $70,000 already secured in the Highmark Communications budget that has been approved for this reason if this were to move forward. So we do have 4 options on the screen here. The first two on the left-hand side would be the cost for the 50-person pilot, and the 2 on the right-hand side would be for the 100-person pilot. Again, looking at those 2 options of the 245 maximum versus the 275 maximum. So the cost of the pilot would range from either $54,000 on the lower end for a 50-person pilot to $66,000 on the higher end for a 100-person pilot. And as you can see, the top 3 rows, so that would be the TheraPay subscription fee, program development fee, and the performance bonus cap. Those are the same regardless. We wouldn't be having to pay more for program development or a subscription just based on the number of people in the program. The only change would be, of course, the rewards. Knowing that we would have more people in the program to reward, those costs would increase. So the furthest column on the left, the cost just under $55,000, that was what was presented in October. But again, wanted to provide those additional options to enhance the program as well as increase the pilot. Expecting that we would have about 80% of people who enroll complete this full 12-month program. It looks like, I believe Mr. Oberle has his hand raised.
Yes, thank you. The $70,000 that we're receiving from Highmark to cover the cost of this plan, that's one-time money?
So to clarify, this wouldn't be receiving directly from Highmark. This is already established in the FY25 budget within the group health insurance plan. This is included in our previously established communications fund, which we already did verify. We would still have enough funds in that account to cover the traditional communications we would have with Highmark. But yes, this would just be a 1-year pilot. Hopefully, once this 1-year pilot is complete and we're able to see success or any follow-ups to that, the SEBC could consider expanding the program the following year as well. But yes, this is just a one-time pilot with the expenses accounted for just in this one circumstance. That is correct.
Okay, thank you.
And it looks like Bert, you have a question as well.
Sure, thanks, Stephanie. Yeah, I think it's good timing looking at this right after Walt's presentation before on some of the diabetes numbers, which are big. Just a couple minor questions. What happens if you said there's 3,200 employees, I think, have been identified as potentially using this program, right?
Yes, that is correct.
What happens if we oversubscribe it, is it the first 100 that get, do we cut it off after 100? Or is it first come, first serve? Or do you just let anybody in?
Yes, so this would be specifically, it would be cut off after 100. We did speak with Reciprocity. They would have an option for when people were signing up, if we already hit that 100-person cap, for members to sign up if they are still interested, to gauge the level of interest. So say we approve a 100-person pilot, but there's over 300 people that are interested, we could take that back to the SEBC for further consideration. But it would be cut off to the first 100 people. That is correct.
Okay. Just another question on the option 2. How do we measure success? I mean, I see it on option 1 because it would be, I guess, weight loss. But is our measure of success in option 2 just that they're engaged?
So we would also have weight loss being reported. They just wouldn't be incentivized for it. So the way that we currently receive reporting from the YMCA, percentage of weight loss is included in that, and that would not change. The only difference in option 2 is that members would not be incentivized specifically by their weight loss at the end of the 12-month program. The incentives would be based on the number of meetings that they attend. Most other studies and retrospective reviews of programs such as these show that you do get those better outcomes the more meetings that people attend. So we would expect to still see higher levels of weight loss with that second option, and we would still receive reporting on it. It could definitely still be considered one of the metrics. Members would just not receive additional incentives at the end for percentage of weight loss.
Gotcha. Thank you.
Any additional questions on the pilot size options or the cost options and the timelines that we presented? Next slide, please. Great. So this just leads us to next steps and, of course, any additional discussion. So what we would like at this time is for the Health Policy and Planning Subcommittee to make a recommendation. Actually, there's kind of a 3-part recommendation. So the first would be whether you recommend this program as a pilot for calendar year 2025. Assuming yes, would you recommend the 50-person pilot or the 100-person pilot? Noting, of course, the additional cost is really only based on incentives. There's no additional program fee depending on size. And then the third part of that would be, is there a specific timeline that was presented that you have a preference for? So I'll open it up for discussion and for any recommendations from subcommittee members.
I'll make a recommendation for a 100-person pilot at option 2.
Thank you, Bert.
I would second that.
Thank you. Was that Matt? Yes. Please, Matt.
Yes, yes.
Thank you, Matt. Is there any discussion on the recommendation or any oppositions to Bert's recommendation? Looks like Mr. Overly.
Yeah, the option 2 does not have the weight loss incentive, correct?
That is correct. However, it will still be measured. They just will not be incentivized for the weight loss percentage at the end of the program. Any oppositions to the recommendation? If not, we'll move forward with recommending this to the SEBC at their meeting on November 25th. Thank you very much, Jacqueline. I think we can move on to the Highmark virtual health enhancements.
Hi, everyone. Michelle Gass from Willis Towers Watson. I'm going to walk us through the Highmark non-Medicare virtual health program enhancement proposal. So moving into the summary slide. So the Health Policy and Planning Subcommittee has seen this topic in the September and October meetings. And then on this meeting today, we're primarily focusing on the follow-ups from that October meeting. So in September, at the Health Policy and Planning Subcommittee meeting, we reviewed what the enhancements are to the Highmark Well 360 program. So those are focusing on allowing options for virtual primary care, virtual women's health, and dermatology options. In September, we reviewed the follow-ups. Follow-ups were raised, and we reviewed them in October, which were around the implementation timing for these enhancements. There was follow-ups asking if we could negotiate the admin fee, which was also discussed. Communications and the associated cost, as well as additional research regarding those enhancements that are offered through telemedicine, and the effectiveness of those being done virtually versus in person. So those were the primary discussions in September and October, and the details of those discussions were in the appendix of this presentation today. Following the September and October meetings, there were also some discussions and questions raised from the Health Policy and Planning Subcommittee meeting, which the SBO, Willis Towers Watson, worked together to gather information both from the claims data that's available to the SBO and the state, as well as working with Highmark and Aetna to connect with the Teladoc and Well 360 programs to understand what data was available regarding those questions. So I will go over those additional follow-ups that came up in October and present those today. And then the goal of today's discussion is to have the Health Policy and Planning Subcommittee make a recommendation for the SEBC when this is presented next week on November 25th to them. And that summarizes kind of where we are today. Any questions before I move on into the follow-ups that were raised during the October 21st Health Policy and Planning Subcommittee meeting? You can move to the next slide, please. So the first question here that was a follow-up from our last meeting is around what is the prevalence of virtual visits that are then moved into an in-person appointment following that virtual visit. Unfortunately, both Highmark and Aetna were not able to provide this information. They did reach out to the third-party administrators to understand from both Teladoc and the Well 360 program if those are data if that is data that's currently gathered and available that can be provided, and it is not. So that's not something that they were able to answer. And also from the SBO side, the claims data does not particularly store this information. So that was not an item we were able to provide specific details on. We were able to look further with the SBO into the claims data for this next item, which is around what is the percentage of the GHIP members who had a virtual visit that then went to an in-person provider for the same type of service. They were able to look at the three primary telehealth diagnoses in the past 2 years. This was excluding mental health and behavioral health, and specifically looked at the virtual visits that were then followed up with an in-person provider within the next 60 days. Looking at those top three conditions, for Highmark Well 360, there were 8.8% that went to an in-person follow-up. And for Aetna specifically with Teladoc, there were 14.2% that within the 60 days of that first initial virtual visit went to an in-person. The one thing we want to caveat with is there's no specific information that proves this was exactly the same condition, meaning they went for in-person care for the same exact acute episode. So we do want to point that out, although it might be the same diagnosis, it could be that it was two different specific situations for a given member, and it's just coincidental that it happened within that 60 days. But that is at least the information we were able to gather at this point in time with the data that was available. The next question is around virtual dermatology services that are currently in place for Aetna members? Is there any specific data available for the efficacy of Aetna's virtual dermatology program and the number of referrals to an in-person dermatologist? So the information available from the Aetna team when working with Teladoc to date is that there are 220 members that utilize the Teladoc dermatology services over this 2-year period. Over that 2 years, the primary diagnoses were acne and dermatitis. And of those that utilize the dermatology with Teladoc specifically, 30 members followed up with an in-person provider within 60 days. So that's 13.6%. And the average time between a virtual visit to an in-person visit was 16 days. There is no actual member satisfaction data that was currently available from the Teladoc dermatology services to provide to the Health Policy and Planning Subcommittee today when requesting that information from Aetna, who coordinates with Teladoc. The last follow-up here was around if there was anything in the program that ensures that the in-person contact is done with urgency, and understanding that if somebody had a virtual visit and they need to move to an in-person, is that treated with urgency? And there is nothing specifically that is in the telehealth program that allows for that currently. And the reason they kind of went back to us with is that they are not currently affiliated with the Highmark or Aetna provider network. So that's not something that's possible to date. They can utilize the care management program and coordination services that each provider has with them currently to set up in-person follow-ups if necessary, but it's not something that is done directly through the Teladoc services or the Highmark Well 360. In the last discussion, the subcommittee also just made mention, so we did want to flag this here, that they discussed that when they make the recommendation to the SEBC, including information around the performance and utilization targets, if they have that regarding their recommendation to the SEBC. We do additionally have throughout this deck just the information that was provided previously. Hopefully that was helpful to the Health Policy and Planning Subcommittee so that you have that information when thinking about whether you want to make a recommendation to the SEBC and what that recommendation is. This should be all of the information at this point that has been requested from the Health Policy and Planning Subcommittee in addition to the discussions to date. I see a question. Is that Mr. Oberle?
Yes, it is. Going back, the 3 primary diagnoses, can you tell me what they were?
Specifically, it's ENT otitis media is the first one, then respiratory, and then eye. They were the top 3 that were listed.
Second question, this relates to the Aetna, the 220 members that utilize Teladoc for dermatology. Is that Delaware centric or is that nationwide?
My understanding, oh, sorry, go ahead, Stephanie.
Sure, Michelle, I can jump in. So those are group health insurance plan members. So those who are enrolled in the state of Delaware plan. Can't necessarily confirm if they live in Delaware. It may be a state of Delaware employee who lives in Maryland who utilized the service, or maybe an early retiree who lives in Florida. However, they are all group health insurance plan members in that total.
Okay, thank you. All right. I mean, I have a number of questions, but I don't want to go on and on at this point. I just worry about the efficacy of the program. Overall, the existing Teladoc and what we're proposing here. But I just generally have some concerns. Thank you.
Any other questions?
Yeah, I'm gonna see if I can lower my hand. My question is just kind of, and I don't know that you have the data here, but the one thing that I worry about with some of these individuals, 220 individuals that are seeking care through teledoc, for some of these conditions, is whether or not they're engaged with a primary care physician and what the billing looks like with these visits, these specialty visits. Are they billed as a specialist in dermatology? Are they billed as primary care visits with a higher level of care? Because that is, it's a concern for continuous care that's sort of steered in the most appropriate manner. And then I guess and again, I don't know that you can answer this question, but as far as in-person, I see the referral to in-person dermatologists. So I'm sort of assuming that they're going from a dermatologist to a dermatologist, MD or DO, you know, and what that, I don't know if you have clarification on that.
So my understanding is like this data is just for us to understand if somebody went to an in-person provider and then following that appointment, they then needed to go to an in-person provider. I think similar to the follow-up above this, we don't know that it was necessarily the exact same scenario, meaning their first visit caused them to go to in-person. But I don't know, Stephanie, when you gathered this information for the second piece with Aetna, it's the same as the first, meaning you don't know necessarily that it was for the same reason, correct? It's just dermatology.
Correct. There are no specific referrals provided from Teladoc or Highmark Well 360 that we have any record of. Unfortunately, as you had mentioned, Michelle, they do not keep track of that or report out on that. So we do know that out of those 220 members, 30 of them did follow up with an in-person dermatologist within 60 days. However, as Michelle noted, they could have had maybe they did a teledoc appointment for poison ivy, and then 60 days later, unfortunately, was reinfected with poison ivy. We don't necessarily know if we cannot necessarily attribute that it is an exact referral, since there are no, unfortunately, there's really no paper trail of referrals from teledoc or.
Okay, and then I guess my earlier question is really whether or not these individuals have primary care physicians that they're seeing on a regular basis, or practitioners, nurse practitioners, PAs, if they have a regular primary clinician that they see on a regular basis, and whether or not you have that data.
I don't think that we have that data specifically from this analysis. I don't know, Stephanie, if that's something that's available that we can work to get, but I think this information was specific to understanding the exact follow-up of how many people are using the dermatology program. But as for that additional, do they have a primary care physician? I don't know that that was currently gathered with this.
Michelle, we can definitely get that information. I will say, if they are enrolled in the Aetna HMO plan, you are required to have a primary care provider, at least documented, to enroll in that plan. But that's definitely something that we can take and look at, is whether the members who are attending the virtual visits through Teladoc and Well 360, if they are attributed to a primary care provider.
Stephanie, will, at the risk of putting you a little bit on the spot, do you think that's data we would be able to pull to report to the SEBC at their meeting next Monday?
We should have at least some high level stuff. Yeah.
Thank you.
Are there any other questions on these follow-ups that were from the last meeting? And I think on the next slide, the key next step that we're looking for is for the Health Policy and Planning Subcommittee to make a recommendation to the SEBC on whether you would like to recommend having the Well 360 virtual health program expanded to have these additional options available. And again, those are the primary care, women's health, and and dermatology being added into the current program.
I guess my only other question with regard to this in particular, this expansion that we're talking about, is, what the timeline is as far as when we'll be reviewing whether or not this was something that was worth doing, whether it was important, whether we achieved our goal, and maybe defining what those goals are very specifically. So do we have a sense of what we would like to achieve with including women's health, primary care, in this expansion?
Are you asking me specifically that question? I just want to make sure to it's directed at.
Well, Michelle, if you want to chime in, please do. But I think I'm just kind of asking everyone here on the subcommittee, what is it that we're trying to achieve by including the Well 360, and sort of expanding the utilization options?
The one thing I would just flag, I know we mentioned it just from the Willis Towers Watson and SBO side, is currently Aetna, the Teladoc program, does have dermatology as a part of their virtual services, and the Highmark Well 360 does not. So that would kind of align the two, is at least what we discussed to date. The others, though, would set it apart. So I just want to flag that as what we've discussed. But of course, the subcommittee can discuss the additional detail there.
Yeah, but it sounds like there are two distinctions. One is that we have primary care that's required under Aetna. So we know that individuals are being followed on a regular basis by some type of primary clinician who's going to ensure that they, hopefully, we're hoping they'll ensure that they get proper care. And what I don't hear is that we have the same type of opportunity or policy from a Highmark member perspective. So that's kind of my concern, is that and again, if you're not in this space, you may not understand that you could have a clinician who sees a patient for a dermatologic issue who is actually a primary care clinician who's going to bill at a higher level for that interaction. And then it makes it harder for the primary care physician or clinician to recoup the costs for their annual visit because of the way that the billing is done. And sometimes the individual who's receiving care will be asked to pay that and not know that they're not really required to pay that. So my concern is that we start to get into sort of some muddy waters from a payment side that our members may not be aware of. And I frankly don't think that the subcommittee members are fully aware of either, how this process happens on a payment side. So again, if we don't have the ability to ensure that people have a primary care physician that they're receiving an annual visit with, it makes it a little bit concerning that we'll actually end up driving people away from getting that annual visit with their clinicians.
Treasurer Davis, it's Faith. I'm tracking with you, and I think I'm still somewhat focused on your question about goals. I mean, you know, from my point of view, when Highmark brought this proposal to the SBO, I think, you know, we were seeing this as an opportunity to improve access. I certainly, and I think I'm, you know, beyond that, I think I'm struggling a bit to define goals. I certainly can appreciate, and I think we could perhaps have some more internal discussion about how to better track, perhaps across all virtual care, whether or not those individuals have relationships with the primary care physician. Because I mean, we're obviously doing work around that already. That's really important for everyone to have a PCP. But I also recognize there's limitations with virtual care and our ability to get data that I think might be needed for, you know, really meaningful goals and targets, regardless of what those might be. The billing piece, I'd almost be interested in perhaps taking that offline and talking with you a bit more. I mean, my understanding is, at least, I realize that some of these providers could be primary care physicians or specialists, and also working for Amwell and Teladoc. I don't know to what extent, like what their reimbursements are as a primary care or specialist versus what they would be paid through Teladoc or Amwell. I don't know if that's like having any impact on, you know, how they're going to see members, right? And I'm not sure if that's really your concern. Again, I'd be interested in, I think, taking that offline a bit, because our understanding is there is a set amount that they're going to be paid to offer their services through Amwell or Teladoc. I don't know how that compares to what they would be reimbursed through Aetna or Highmark as a participating provider outside of the virtual care services.
Yeah, I'm happy to have an additional follow-up conversation. Sorry.
It sounds like Stephanie might have some comments to add to that too.
Sure, just a quick comment. It looks like for this Well 360 program, the price for a primary care visit would be $75. However, on our Choosing the Right Care website, our Choosing the Right Care page on the DHR SBO website, it looks like the average cost per visit for an in-network PCP is currently $169 for in-person care. So it would be the average cost per visit is actually the same for both Highmark and Aetna, of about $169 versus a $75 charge for the Well 360 primary care.
And that's charged directly to the plan, or is that what the participant is paying?
That would be charged directly to the plan. That's not the out-of-pocket cost, to clarify.
And I think we should have a conversation offline, because I have a lot of questions, but I apologize. I think someone else was chiming in.
No, I had raised my hand. I too have a number of lingering questions, and I appreciate Treasurer Davis for raising this issue. I would hope that at this point we not move forward until we clearly understand all these issues. I mean, I have concerns, as I mentioned earlier, around efficacy and redundancy. And a number of months ago, I raised the issue about the efficacy of a virtual visit with a dermatologist and the possible negative ramifications around that. So I would hope we would not move forward with this recommendation of the SEBC at this time.
Other comments from subcommittee members? Thank you, Bill, and thank you, Treasurer. We will circle back to you and see if we can set up some time to talk more specifically about some of your concerns. Okay, I think that brings us back to the agenda. Do subcommittee members have any other business that they would like to bring forth today before we move to public comment? Right. I'm gonna turn to Carol. Carol, do we have anyone pre-registered this morning?
No, I don't have anyone pre-registered this morning. Subcommittee members did receive a written public comment that was by Bob Clark in last week. And I do see Stephen LePage with his hand raised. You can, you should be able to unmute, Stephen.
Okay, can you hear me?
Hear you.
Oh, great, thank you. I just wanted to circle back a little bit about the imaging radiology part that was discussed. I recently had a CT lung scan where I went to a freestanding facility, and after I compared the cost, it was substantially lower. I think it was something like 600 versus 3,200 or something like that. And as Faith mentioned, a key consideration is whether the complexity of certain diagnosis necessitates the use of hospital-based imaging services instead of freestanding facilities. But in addition, I would add to that it is also important to examine the role of physicians in this trend, specifically whether they are directing patients to hospital imaging services through their referrals, potentially limiting patient options. Another question is whether Delaware has a sufficient number of freestanding imaging centers to foster meaningful competition and help reduce imaging costs. Also, is the state actively promoting the use of freestanding facilities over hospital-based services through its outreach efforts? Are there specific incentives, such as reduced copays, to encourage patients to choose freestanding facilities? And finally, has the State Benefits Office identified those freestanding facilities and effectively communicated this information to employees and retirees? So I would think that in addition to Faith's comment, that these other things need to be looked at as well in order to get people to drive more to freestanding facilities versus hospitals, which are more costly. Thank you.
Thank you. Is there anyone else that wanted to make a public comment today? I don't see any other hands raised.
I think that brings us to the end of today's agenda. Appreciate everyone's time this morning. We'll certainly summarize the feedback from the group as we continue these discussions with the full committee. Certainly will entertain a motion to adjourn.
This is Bert. I'll move to adjourn.
Thank you, Bert.
Second.
Thank you, Treasurer.
Have a good one. Thanks so much.
Thank you, everyone.